Welcome to the second day of our winter meeting in 2025. Happy to see all of you here this morning. We're going to get started with our industry session, which will be kicked off by my co-moderator, Dr. Koen Nieman. Koen?
All right. Good morning, everyone. And so for the first talk will be Johan de Mey, and he will be talking about HeartFlow, how quantification, quantitative coronary plaque informs patient care. Thank you.
Thank you, Mr. Chairman. Dear audience, maybe we can have the first slide. In 10 minutes, I will go fast over the new developments and the way we look at plaques at the moment. Next. So I think CCTA and FFRCT is mature at this moment. This is something we can say. Already in 2003, we had really nice anatomical images, and we could decide about the anatomy from the patient. But anyway, it took more than 10 years before going deeper into analytics and have the physiology and the FFRCT, which in 2017 was used already in our hospital and proved to be really valuable. And then we go further. CT is going faster, rotation is going faster. You see less noise. You see all the other kinds of possibilities with the new CTs. And in 2022, we come up with new plaque analysis and the really useful roadmap. So AI and analytics is helping us really well. And I think in the future and already now, we have the photon counter, and photon counter is really promising in plaque analysis, but also in spatial resolution for stents like you see here. This is a stent we did scan on a prototype of GE, and you see on the left the image from a state-of-the-art CT now, and on the right the photon counter CT. So I really believe that photon counter is still going to change everything we see about plaques and analytics from the heart and the coronary arteries. So how to tackle this at the moment, like we do it, so you just do your CT, and if everything's normal, then it stops. If you see no plaques, you see no stenosis, you decide about primary prevention. But if you see plaques, we go to plaque analysis, and if you see stenosis and plaques, you do them both, FFRCT for the physiology and plaque analysis. And then I get an interactive exploration report of the plaques and the stenosis, and I really like it. As a radiologist, I'm used to look at images, but I think this is not enough anymore. You have a stack of 5,000 to 10,000 images. If you do a cardiac CT, it's impossible for my brain, and probably for most of you, to tackle everything. So I like AI, and I like the presentation of the images and the data and all the data quantification together in one or two views. So what's the key evidence now about this AI plaque quantification? We have some questions. Is it as accurate as the gold standard IVUS? What does this measurements mean for a specific patient? Does it predict the patient risk? And how to deal with it as healthcare provider, and what about the outcome? I think the Miami study proved that the CTA, plaque analysis and analytics are mature and helping us. It's reaching out to the level of IVUS, so I think this is really, at this moment, something which is proven and can be used in clinic. And also the REVEAL plaque study showed that those data of CCTA and plaque analysis are robust. We have also, based on a huge amount of patients, the normograms, which we can use if we have a patient with some other values and some plaques in the arteries. So we can base those patients on those normograms, which helps also to decide about treatment. And then the decodes, the advanced registry study showed us that if we have plaque, even on 1 year, you see that a huge amount of plaque, total plaque, non-calcified plaque, or even a little bit of low attenuation plaque can change the way patients are healthy or not. And so I think those plaque data really need to come into clinic, and you need to take them into account. This is what has been done in the DECODE study on 100 patients. So they decided for the stage 3 patients, the stage 2 patients, to divide them into 3 groups. One got a little bit better if you have the plaque analysis, one stayed the same, and one group became worse and had to be treated more accurate with other possibilities. What's a little bit annoying for me is that we're going up for the most patients and not going down. So I think we have to watch out not to overtreat patients on long term, and this is something we still have to tackle. What's the important on long term to treat all those patients really heavier than we did before? And this is something you all know probably. It's the standard medical management recommendation. I won't go into deep about this, but you see indeed that total plaque volume has its value in deciding how to treat the patient. And on some case examples, here you see patient A, which has high-grade stenosis and an impact on the physiology, on the LAD, and then patient B, which has no high-grade stenosis. If you look at them as MACE risk on near term, I think patient A is high risk and patient B is low risk. And then if we go to the analytics of the plaque, you see that patient A has a low-term MACE risk based on the plaque, and patient B has a high long-term MACE risk. And if you place them on the nomogram, you see also the differences. So it's quite complex now to decide about treatment for those patients. Some have physiology problems, some have plaque problems, and I think we still need to decide how to tackle this in cardiology, and most of you will talk about this those 2 days, and I think it's really interesting to hear about all the other thoughts. Another example, this is a patient with low-grade stenosis, just a small impact, just below 0.8 on the physiology. And again, if we do the plaque calcification, the plaque quantification, you see calcified plaques, you see soft tissue plaques, you see some low attenuation plaques based on these data. And I think we need to change treatment of this patient based on this plaque analysis. If I come back to the key evidence questions, I think accurate, yes, the Miami study proved that it's reaching out to the level of IVUS. Does it mean something for a specific patient? I think yes. Yeah, we changed treatment of the patients based also on the studies we did, the advanced registered study. Does it predict patient risk? It is predicting patient risk, also proven in the advanced study. And what does it mean for the healthcare provider, and what about management and outcome? I think it's proven that there is an impact. I still think we need to think about how to tackle all these data and how to treat patients with all those data. So as conclusion, I think CCTA and FFRCT are mature. It's time to focus on plaque quantification and characterization with AI. And then 2 remarks. I think CT is still in evolution. And most of you have heard the talks yesterday and probably today also. Watch out for different scanners, different resolutions, different reconstructions, different quality. I think we need high quality to go for high quality analytics. And the photon counter will certainly open a new window on those plaque characterizations and the possibility, but this is also something we still have to learn. And I would like to end with a quote of our colleague Jonathan Leipzig, who says that it's an interplay between plaque physiology, high-risk plaques, features, plaque progression, between everything. It's an interplay, and we need to think about how to manage and how to tackle all those things together to decide about patient treatments. Thank you very much.
If there are any questions, we have 1 or 2 minutes. I think you can use the app. You can also come to the microphone. If there are any questions, maybe I'll start first. I mean, we can do very precise plaque measurements. How do you think the reproducibility is, let's say, between scans? Do you think that, if you do the same scan, you will get similar answers? Because the numbers are so precise, it's hard to keep them the same every time.
Yeah, I think you have to take into account the standard deviation. I don't know how much we should take into account, but I believe if you have a high quality CT scan without too much noise and without movements, I think it's quite robust, which is also proven in the Miami study. The problem is when you have a low quality CT scan, I think you should not take into account the analytics, because at that moment, they're not valuable enough, in my opinion. Yeah. So quality of the CT is one of the first things we have to tackle before we go to analytics and AI.
Yeah, that makes a lot of sense. Please.
Yeah, thank you. It was a great talk. I just want to add to that. I think not only do we need high quality images, but we also need some kind of standardization or even guidelines surrounding scan and reconstruction parameters, because they will hugely influence the measured volumes in these types of plaque analysis tools, is our experience.
Yeah.
So I would really want to highlight that too.
Yeah, I agree. I think we need studies between the different scanners and the different reconstructions, different possibilities we are scanning now. But it's quite difficult because the scan is that fast in evolution. So every company is coming with new software, new reconstructions every 6 months, new scanners, and I think it's quite difficult to compare them. But I'm really open to do this with other vendors and to see what's the impact of this. We did a study like this for MRI and quantification in AI, because we have the 3 vendors from MRI which are used in Belgium, so Siemens, GE, and Philips. And then we've seen, even for that quantification, huge differences. So I completely agree, we should have standardized it. Yeah.
Thank you. Outstanding presentation, but I wanted to emphasize something. I do MRIs as well, and you are coining very well in terms of the scanning and, you know, pretty much which platform or vendor do we use. In the MRI field, oftentimes software companies or workstations tend to quote, adjust or prefer certain manufacturer.
Yeah.
Does this apply to these two? You point out very well.
Yeah.
It depends on the scanning, the machine, the company, the software, and so forth. And I don't want to really like corner you, but is there any specific manufacturer that software analysis, or it varies?
Yeah, no, at the moment we're using the GE scanners as a platform. We have in our hospital also Philips scan, we have a Siemens CT scan, and we have a Canon CT scan. So we have them
And
all.
so with the
We have them all 4, but for the cardiac we go to GE because it's a newer machine and it's the machine where we do the cardiac. So I don't have experience on the other machines, but I really would be open to exchange data, and we did it for Siemens with people from the Netherlands and make comparison between the Siemens and GE scans, but it's already 4 years ago, so it's all data.
So that's a good point, because, you know, pretty much, at least in the MRI field, what I do, I'm an invasive interventional as well, so I do both. And so when it comes to what you express, like for MRI, GE seems to be the way to go in many vendors. Yeah. And your experience, know that you don't, is just GE, right? Yeah. Thank you.
Okay, thank you very much.
Absolutely, thanks, Johan. All right, it's my pleasure next to introduce Scott Galbari from Circle Cardiovascular, who'll be talking about next-gen AI. Scott?
Yeah, thank you. It's a pleasure to be here this morning to talk with you guys. I'm going to start by just giving you a little bit of background about who we are, because you might not know us right away. So Circle Cardiovascular Imaging was founded in 2007 with our roots in cardiac MR. And we have widespread global adoption of our solutions. 100% of the top 10 hospitals in the world use our solutions, as well as 100% of the top 25 cardiac institutions in the US use our solutions. And as I said, if you know our name, you would recognize us from our MR solutions, right? So we have developed very mature cardiac MR solution. We just had someone talking about MR, probably very familiar with our solutions. And over the time, we learned how to do post-processing image analysis for cardiac MR studies. And we applied that knowledge of both cardiovascular imaging as well as AI and ML into the CT domain. And so what I'm going to highlight for you today is just some of the things we have done around diagnostic and interventional planning CT applications within Circle. Our solutions today are used by both researchers and clinical users for various use cases. So you're gonna see that if you're in this room, some of you are researchers, a lot of you are researchers, some are clinical. Our solutions are used for both. When we work on our solutions, we try to focus on the AI improving accuracy, efficiency, and reproducibility for our end users. Now, when I'm talking to people here at the conference, a lot of people ask us about calcium scoring. And of course, we have a fully automated calcium scoring solution, but I'm not going to talk to you about that today, because that's not as exciting as some of the more modern AI/ML technologies that we have. So what I want to do, though, is take you on a little bit of a journey on where we came into cardiac CT and what we've done. So the first thing we did is we built an application called Watchman TruePlan, which is used for LAA closure procedures. And we essentially built up a solution to automatically segment out the left chambers of the heart and the left atrial appendage to facilitate planning for placement of the Watchman device. And this helped us to really apply our AI and ML technologies into CT imaging. And I'm going to come back to that in a little bit and tell you about some of the outcomes. From there, we expanded into full volumetric segmentation of the heart. So we essentially were able to do a full segmentation, which we took a more novel approach. We trained our models to the more traditional approaches in the industry that use 2D segmentation, where you would go slice by slice and try to identify anatomy in the images. We actually build up a 3D model, and then we go and trained our networks on that 3D model and do the segmentation. So it's a more accurate sort of approach by using a 3D representation rather than a 2D representation in which we were stitching that back together again. In our solution, you're going to find out that I'm going to show you a little demonstration here in a second. We always try to make sure that everything we do is user editable. So although we look at automating as many things as possible to make our users more efficient, we always want to put you in control. And so we always want you to have the ability to modify some result. Rather than it being a black box, you're giving it to somebody else and getting a result, we want to make sure that you have the ability to see where the results are coming from the AI and ML, and then try to make sure if there's adjustments you want to make that you can do that. Now here's an example, loading a study in our core application, our core CT application. And what you'll see is it automatically segmented all of the major structures of the heart. And it did this really quickly. I mean, you just saw it very quickly loaded. You see that it automatically identified the structures and calculated all the volumetric measurements over there on the right side of the page. And all of that with 0 click, right? So gone are the days when we would sit down and we'd have to do a lot of contours, or we'd have to go and do the manual segmentation on slice by slice of the images. We are now able to do a 0 click sort of heart segmentation. And as you can see, our results are quite good. We have over 80% DICE, less than 10% volume error for LV, and an infection bias of only around 1%. Once we completed full segmentation of the heart, we extended into coronary extraction. And for coronary extraction, we trained our models on over thousands of vessels. And so when you, for those of you that are really familiar with AI and ML, of course, data is the thing that you need. And so we work with our customers on collecting a widespread variety of data, because all of our solutions, we go and get regulatory clearance in all of the geographical jurisdictions. And so we have to have representative samples of all of the data that we're training and then that we're using to validate our solutions. Now, what I'd like to highlight about our coronary extraction is that you can see it automatically, again, is able to identify all the coronaries, label them accurately. The user is able to go and look at those. They can select any of the coronary arteries. They're able to then go and look at a particular a vessel. They can see an automatic calculation of a lesion in that vessel, and then they can actually understand how much stenosis there is in there. With all of our solutions, although you see it's very quick, we're running these, of course, I don't have a full demo here, but I'm able to just create the video. You can see it's 0 click. But in the end, we give the user the ability to edit these things. So if we have some things that, the algorithms aren't able to get it perfect, or you want to make some adjustments, the user's able to do that within the application. Again, the accuracy, the true positivity rate of over 87% for the LED, almost 83% for the LCX, and over 94% for the RCA gives you quite good results. Another thing about the model that we trained, for those of you that have used vessel segmentation throughout your career, the way this used to be solved is you would essentially go and find the vessel. You'd go and identify a point in the image stack, and you'd say, hey, this is a vessel, I'm going to identify, I'm going to name this vessel, and then I'm going to go extend it. And I'm going to go and find how to grow this vessel. Well, that's a growth-based algorithm. That works really, that worked pretty well. I mean, that's a good solution. But over time, you start to recognize, we had a lot of cardiologist friends who would say, hey, those solutions aren't very accurate, because if you have a high-grade stenosis or complete occlusion, it's not going to be able to find the rest of the vessel. And so you probably all, see some people nodding their heads. You probably have seen this sort of thing in your practice. And in those cases, the traditional algorithms wouldn't find the whole vessel. They might even just start to label lots of other vessels. They'd start creating new vessels that didn't exist. And what you can see with this quick diagram here, you can see that we're able to find the center line through that vessel all the way down to the bottom, even though there is a very high-grade occlusion there in the vessel. All right, we also then, once we're inside the vessel, we've built up a plaque-based analysis. I mean, there's a lot of discussion about plaque, and we just heard Johan talk a bit about plaque and FFR. And so we have built up an automated solution around plaque. Again, we give the user the ability to modify those measurements that we find, but we can get calcified plaque, non-calcified plaque, and low-density non-calcified plaque very quickly for our end users. Now, I want to go back, as I said, to the procedure planning. So I mentioned we use our solutions are used for diagnostic use cases and interventional planning procedures. And I mentioned this TruePlan solution that we have. And what you'll see on the screen here as it's just running through the video is that you can see we can find the LA landing zone very quickly, less than a second. I mean, this is a really quick sort of algorithm that runs. But the thing that I want to highlight is not necessarily for the imager, it's like less than 1 second. Of course, you're going to feel nice because that's really quick. It's easy for you to plan for this procedure. But what's more impressive is that when we worked with a regional medical center in the US that used this sort of application for planning their procedures, they're able to reduce their procedure time by 30%, which is great because that means a lot less radiation, a lot less contrast for patients, but also meant they were able to increase their procedure volumes, their LA closure procedure volumes by 50% every day. So this sort of automation through planning is super helpful when you get into the actual interventional space. One more example of a planning procedure that we have created is TAVI. I mean, we've all worked with TAVI applications in the past, and these can be quite cumbersome to go and calculate all of the different measurements that you need to collect when planning for a TAVI procedure. And so here I'm going to give a quick demonstration of our TAVI application. You're going to find, don't blink because this is really quite quick. You're going to see that we're going to get all of the key 13 landmarks for TAVI procedures completely automatically when this loads. And so when we show this to people, when our friends come in and take a look at this, they say, hey, well, did you already process that study? No, this is a full AI ML that we've built up to go ahead and get these landmarks. We're able to do all the calculations on the fly, and end users able to get the measurements added to a report. You can add key images. Quite honestly, the most work that a user is doing is just validating that they're comfortable with those measurements. If there's something wrong, they can go and change the cusp points. It'll recalculate very rapidly the results and get those back to the end user. And so what you're going to see with our solutions with AI and ML is that we're focused on this automation, but give you the control to continue to edit and make slight modifications where necessary. You saw very briefly that all of the results were being put into a report. So part of the automation that we focus on is how do we automatically create these reports and create the outputs for end users. So that's part of our solution. As we look at this journey towards using more modern AI and ML, again, we look at improving speed, we look at improving efficiency, we look at improving accuracy and reproducibility. And so although our talk's about modernizing AI and ML algorithms, what you're probably going to see with us is we prefer to think of it not as artificial intelligence, but more augmented intelligence. And we give you the ability to then go ahead and make modifications to the automation that we've created. Thank you. Yeah.
I'm going to try to stay within time and continue with the next presentation. This will be Niels van der Werf from Philips talking about the advantages of spectral CT in cardiac imaging.
Yep, thank you very much. So good morning, and in the next 10 minutes I would like to tell you something about our cardiac one-stop shop, so the advantage of always having the spectral data in cardiac CT. So traditionally this is coronary CTA, so with any high-end CT system in general we can look at the lumen of the coronary arteries at high image quality and low radiation dose. And the reason, of course, we want to prevent unnecessary invasive procedures. But then there's an entire list of things we cannot do. So we cannot assess hemodynamic significance. We cannot assess all of the other things. And for that, we have a solution which is called spectral CT. And just by a raise of hands, who is using spectral CT currently in cardiac CT? Okay, so I hope I will spark some interest. So with our spectral CT, so looking at spectral coronary CTA, we have the same basis. So we still have high image quality and low radiation dose. But then we can also prevent more invasive procedures. And I would like to stress this is not a photo counting CT, what is used in these studies. This is the energy integrating detector, the dual layer CT of Philips. And this already prevents more unnecessary invasive procedures. And then there's an entire list. I don't know why the slides are already going. Well, it's fine. So we have an entire list, and I will actually go through that entire list in this presentation. So this is the CT system, for those of you who haven't seen it before. So it's a dual layer detector. You see one element on the left bottom. The nice thing about the system is that it is uncompromised. So you get spectral data in every scan because of the detector design. So there is no impact on dose modulation, on the field of view, on the scan speed, on the rotation time, anything. So you will always have the data. So for that reason, we can do things like this. So this is a non-gated chest, abdomen, pelvis scan in 2 seconds. And it actually allows for the assessment of the coronary artery in the conventional data set, and of course then also in all of the spectral results. For some reason, the clicker isn't working. Yeah, okay, thanks. So then we also have all of these nice spectral results. So in this case, the iodine, no water. Next slide, please. So we also know that coronary CTA, sometimes it's a little bit about luck. So sometimes even with proper patient preparation, you will still have motion artifacts. So for that, we have a new technique, which is called precise cardiac, which is a motion compensation reconstruction. And this is one example of that reconstruction. So it very nicely shows the RCA. But then if we look at the original data, there was a large motion artifact. So from this data, just by applying another reconstruction, we can actually reduce the motion artifacts. In one case, of course, it's always nice to show on a conference like this, but we now have 2 patient studies indicating that we have an increase in image quality for both retrospective and prospective scans. So then to the main topic, the clinical benefit of the spectral data for all cardiac applications. So the first thing you probably would think about is calcium blooming reduction. So in this case, we have a patient with an Egerton score of 1200, which is quite high. On the conventional data set, it's very difficult to discern iodine versus calcium, and then on the high monoenergetic reconstruction on the right-hand side, it's very clearly visible. Then another important topic is in-stent restenosis. So at the point of the arrow, there is a lesion. And of course, one solution to see this better, to visualize this better, is going to photon counting CT. So that's what's shown here on the right-hand side. This is the Philips prototype photon counting CT, and we can reduce the blooming. But we still have an overlap between the struts and the low attenuation of the stenosis. So therefore, our solution is to go to the spectral data. So that's this image, for example, the iodine or water, and now it's very clearly seen that the attenuation is different at the location of the arrow, so of the stenosis. And then we have other maps as well. So if it goes to the next slide. Yeah. So this is the Z effective map, so the effective atomic number map, and here it's very clear that there is something at the location of the arrow. So even I, as a medical physicist, can see that there is something here. Of course, I also need a slide on plaque characterization, because that's sort of the topic of this session, I would say. So here we have a large plaque. And if we want to look at the different components, we can do so. So we can and draw these ROIs. If we only look at the conventional CT, this is what we see. So the red, it's clear, it's iodine. But white and blue, so what is low attenuation? If it's maybe fibrous tissue, it's very unclear. Then if we look at all the energies, so these are the measurements, the Hounsfield units over all the monoenergetic results. Firstly, we get a really nice Dutch flag, but then it also very nicely shows that blue is different from white. So blue must be fat. So this is the signature of fat. So it goes down at low mono E, so we know this is a fat-like composition. And we could also have seen this from the Z-effective map, because also here you can quite clearly see that there is a low attenuation plaque involvement. So having all of these spectral data, of course it is nice, but for any clinician here, it shouldn't harm your workflow. So that's also something we thought about. So what we have is the Spectral Magic Glass on PACS, which is a workflow tool which can open via a single click in any PACS system. And it allows you to look at all the spectral data there are, but also to do measurements, to send data which were not sent from the scanner to the PACS system right at the scan, but which are useful for diagnostics. You can then send those series also to the PACS. So you don't need to clutter your PACS with all the results. You only send what you need or what you used in your diagnosis. And like I said, you can do measurements as well and only send one image if you need this specific image. In this case, this patient had a perfusion deficit, which was quite clear. But let's look at it in a little bit more detail. So this is the first pass perfusion scan. So there is a clear region which is colored. But the question is this region, is it viable or not viable? So would an invasive procedure actually make sense or not? So that's why we also performed this delayed scan. And now it becomes very clear there are two distinct regions. One is non-viable and one is viable. And we can do this in any patient with just one additional scan. And actually these regions of interest, they are based on the extracellular volume map, so the ECV map. And we have already shown that these maps are very consistent and correlated to the MR gold standard. So another indication to use the ECV maps is of course myocarditis. So in this case, it was a patient with chest pain, normal CTA, but there was a slight elevation of the troponins, so an indication of myocardial damage. So we performed a 7-minute delayed late iodine enhancement scan. And then we calculated ECV, and you might wonder how difficult is it to calculate an ECV. So this is the workflow to do so. So we need to draw one ROI, and then we can actually get the ECV, which is a quantitative map. And now I will also quantify the ECV. So in this case, it is at 58%. So the last study I want to show is this recent publication from the University Medical Center in Utrecht. So there was a patient with known sarcoidosis, but there was a suspicion of cardiac involvement, and for that a CT was performed. By the radiologist, it was seen that there was there were no myocardial lesions on just the conventional CT. So then follow-up scans on PET and MR indicated myocardial lesions. But then the next day, the expert cardiovascular radiologist came in and she said, well, let's also look at the spectral data. So that's exactly what she did, and that's what you see on the right lower end. That's again the effective atomic number map, which is very well correlated with the other maps. So with that, I would like to conclude my talk. So I hope I have been able to show you and convince you that spectral data from our dual layer CT can be very beneficial for all your cardiac CT applications. And finally, I want to thank Dr. Dominika Suga and Rolf Rijmakers for the help in creating these slides. And thank you for your attention.
Thanks very much, Niels. In the interest of time, we'll move on to the next speaker. So I'd like to welcome Vishal Karpatri to talk about the NAEOTOM Alpha.
Of course. Thank you very much. So I think we heard a lot of talks about photon counting over the last couple of days. So I'll go a little bit more into it, introduce you to the NAEOTOM Alpha class, which expands on that NAEOTOM Alpha that we have launched about 4 years ago. Essentially, we have a promise that by 2040, all CT scanners coming out of Siemens will be photon counting CTs. And we're starting the transition already. Because we realize there's benefits. We've seen the benefits over the last 2 days as well. But it's still limited to a lot of patients. It's not everywhere, right? We did a poll yesterday where 1/3 of you have access. And we want to expand that. And that transformation has already begun. And this is where the NAEOTOM Alpha class is being introduced. So now, instead of having one CT scanner, a photon counting CT scanner, we have 3, starting with at the NAEOTOM Alpha Prime, which is the new benchmark. This is the first single source photon counting CT scanner. Then moving on to NAEOTOM Alpha Pro, which is a new dual source photon counting CT scanner. And then the NAEOTOM Alpha Peak, the Pioneer, which actually is the original NAEOTOM Alpha, the top of our portfolio essentially, and it stays there as the top scanner, also still a dual source CT scanner. So with NAEOTOM Alpha class, what we have focused on are couple pillars. One being the profound clinical impact. We want to develop that, we want to get that impact for the patients, for the clinicians, and everyone out there. Additionally, we also don't want to forget about the complexity of using CT scanners, especially photon counting technology. And for that, we want to focus on AI-powered productivity that would liaise and maybe make using these scanners actually very easy for different user groups of different types of levels of skills here. Talking about profound clinical impact, within that, what we're focusing on is we are actually able to see the unseen. This is namely because of the high resolution of like 0.2 millimeter slice thicknesses. And especially in cardiovascular, we're really able to then reduce the blooming or look inside the stents. This is the benefit that we see. But of course, it goes beyond that, right? Other parts of the body, also in thorax imaging or whether it be neurovascular imaging, similar benefits can be seen. But I would argue that it's the sexiest in cardiovascular space, and that's where we've seen the biggest impact. Additionally, my colleague already talked about spectral imaging. With photon counting CT, not only you get higher resolution, but you also have spectral built into every scan as well. And additionally, because of that, we're able to do material decomposition. So of course, we can just remove the iodine. But of course, we also have iodine maps and all those things available as well in every scan that is being done. So you have the functional and the anatomical information to a certain degree available within those scans without any compromise. And I talked about the AI-powered productivity. So there is a risk, right? That, hey, this is such high-end technology. Will my techs be able to use this? Will I be able to get these amazing images like what we've been seeing everywhere? Or is it going to be difficult? Well, we've tried to tackle that with our approach of My Exam Companion, which comes to essentially our whole fleet of CT scanners at Siemens. But specifically for NAEOTOM Alpha, it is very important to have that kind of framework so that techs of varying levels of experience don't feel worried about using such a technology. And it goes beyond. It starts from patient preparation to image acquisition, image reconstructions, and even evaluation and post-processing. And there's AI included at various steps to automate as much as possible. Think of it like a GPS for the tech. But in addition to that, also we're working on things on post-processing side, which will further streamline a lot of these things in the future as well. So this is the NAEOTOM Alpha class. And of course, all 3 of these scanners come with this photon counting benefits, which again, smaller detector pixel size, right? So 0.4 millimeters is the standard resolution, and then 0.2 millimeters is the ultra high resolution or the quantum HD mode. Additionally, we throw out the electronic noise because we know where each photon's coming and we can set a threshold. Spectral information because we can bin them correctly into the energy levels that each photon came in. And we have kind of equal weighting of the low energy photons and also the high energy, so you have nice contrast to noise ratio as well. And the output is always a monoenergetic image. Taking a closer look at the 3 scanners, the difference between them, the NAEOTOM Alpha Prime is a single source scanner, but is the fastest single source scanner that Siemens has ever built because it's a 6 centimeter detector width with 125 milliseconds of temporal resolution. Now moving on to NAEOTOM Alpha Pro and NAEOTOM Alpha Peak, both of them are dual source CT scanners. The difference between them actually is only the detector width, which on one is 4 centimeters and the other is 6 centimeters, which makes the scan speed change a little bit. However, the temporal resolution, which is crucial for cardiac imaging, is the same at 66 milliseconds, which means all those benefits that that high heart rates and so on are still capable. a little bit about the detector widths. For us, it's not really an issue as much anymore because we have an algorithm called Z-free, which essentially eliminates stack artifacts anyways. So moving forward, maybe show you a couple cases from these scanners and maybe some publications to round that up. This is an actually example. On the left, you have the third generation dual source CT scanner, so essentially somatomes force compared to a NAEOTOM alpha prime. So a dual source compared to a single source. Here I just wanted to iterate that if you heart rate control, you are aggressive in that, you can still see that the photon counting benefits outshine the dual source benefits at low heart rates, because the high heart rate is where you start to see the benefits of dual source. And the higher resolution of 0.4 already brings better benefits, better visualization when it comes to that. This is not even the highest resolution yet. Additionally, if you add that with the dual source capabilities, you're able to scan really fast. So for example, in this case, is a NAEOTOM Alpha Pro scan, so 1.5 seconds to do essentially abdomen and thorax. But of course, if you go to the peak, you can really push it with the turbo flash speeds of 0.9 seconds to be able to do that. So under a second to do thorax and abdomen, including having the coronaries as well, with ECG gated and everything included. And it's also a spectral scan at higher resolution as well. And of course, we can't forget about the high resolution, the quantum HD cardiac mode, which is what we've seen a lot of examples yesterday. Paul showed a few, Professor Karpatri showed a few. So I don't need to dig deep into it, but what I do want to focus on is what is the effect that is having and what we've been able to see in literature on that. Essentially, what we've been able to see is that this is able to reduce the amount of patients that need to end up in the cath lab. We've seen that in multiple papers, multiple publications. The numbers are changing here and there, but essentially you're reducing the number of patients that would need to go to the cath lab because you're more accurate. Additionally, you're more confident in your reporting, right? So the specificity of CT also goes up, and you're able to grade your stenoses more accurately to what you might have seen in the cath lab anyways. This has a subsequent effect that you're actually able to change the CADRAT score of the patient. So yesterday there was a joke that, hey, how do you get your patients healthier? You get a photon counting CT. So yes, in this case, you are making your patients healthier. However, you're being more accurate to what their disease actually looks like and doing the subsequent testing, downstream testing, more accurately and not frivolously. This, in the end, has an actual financial benefit as well. So there was a small study done recently from MUSC, Semmelweis and Mainz together, looking at a cohort of patients that extrapolating, if you eliminate some of the downstream testing that photon counting eliminates, what would be the financial benefit over a 10-year period, which is what a usual CT scanner is. So you could see up to like $12 million of savings. So yes, the technology might be a bit more costly. However, to the healthcare system overall, it might still have a benefit, which is good for everyone. So this is the NAEOTOM Alpha class, and this is just the beginning, and the transformation is more or less unstoppable at this point. Thank you.
Thank you very much. And then we'll go for our last presentation, which is from Keya Medical, and presentation will be given by Irfan Shafique.
Good morning, and thank you for the invitation. I think they were wonderful talks, and I don't have to go in detail, because that's a segue to my talk. Excellent work done by all the industry and also the presenters. So today we'll be talking about AI-enabled CT-derived FFR analysis, deep vessel, specifically deep vessel FFR. As we are all moving forward from the anatomical assessment, and we all know, as we learned today also in the whole meeting, that there's significant development has been done in the last 2 decades in the hardware, software, and AI tools, all leading to cardiac CT resolution from high to ultra high to super ultra high resolution, and all has led us to the path where we can actually see the characteristic finding of coronary artery disease, and which has also led us to actually getting the measurable indicators, or so to say, innovative imaging biomarkers, which really help us to predict the disease outcome and improve diagnostic accuracy in cardiac CT. Now, how AI has helped us, and this is actually speeding up this whole process, and also greater reproducibility, which is really important, how we can reproduce the whole data as we repeat these things, and also fast labeling of the data. And where deep learning actually comes in, has almost revolutionized our image analysis by improving image segmentation. We all learned that during these talks and also yesterday, quantification of the plaque extent, and also stenosis assessment, which is actually the most fundamental application of machine learning, and identification of the culprit coronary lesions, and also calculation of the composite score, and then leading to the FFR CT, which is really has been in any CTA we talk about, we always talk now FFR regarding that. So we can get, it has become really key tool in coronary CTA for accurate identification of the flow limiting stenosis and enhances the diagnosis and treatment. That FFR CT can be assessed from in different methods, and as you know all, that the computational flow dynamic method, which is a mathematical model and simulates the coronary flow, pressure, and resistance, and provides an accurate, non-invasive way of to assess the stenosis and FFR. Whereas in deep learning FFR, we actually use multi-layer perceptron networks and also bidirectional multi-layer recursive neural networks, which encodes all the data. As you see from the coronary tree, all the structural and imaging data goes into that. And by using multi-layer and bidirectional layer, we can actually compute the FFR, any part in the coronary tree seamlessly. And we have seen that multi-center machine registry has found no significant difference between deep vessel-based and CFD-based FFR CT in terms of diagnostic performance. So, and also has, as you've seen, multiple studies have come out and show that a significant reduction in the cost also, and unnecessary invasive procedures. And we have also seen that there's very high negative predictive value of this FFR CT, excluding adverse cardiac effect in the patient with acute chest pain in the next 30 days of the exam. And that has actually led to the inclusion of FFR CT and plus FFR in assessment and management as a front line in these patients, as the PRECISE trial has shown that significant low rate of major adverse effects compared to the usual care or usual path we take. Really there's the value in applying this between 40 and 90% of the stenosis. When we actually decrease and avoid the invasive angiograms and reduce the cost, and patient comes and gets a CTA. If it's between 40 and 90, you get CTFFR. If it's less than 0.8, go to angiography, otherwise you don't need, and all the studies have really proven by now. So deep vessel FFR is really a flagship product from Keya Medical, which is a global medical technology company specializing in deep learning technology in medical devices, and especially in the coronary artery disease assessment. And they were actually approved by different regulatory agencies and also by FDA a couple of years ago. And now it's very well used in quite a number of centers around the world. So that's actually what it is, basically perform non-invasive physiological functional assessment of coronary arteries using CTA, and you get a 3D interactive model and PDF report of the deep vessel FFR values in this case. So workflow is really simple, and you upload your images on a secure web portal, and deep vessel FFR algorithm runs the FFR, and you can see that the clinician receives the interactive 3D model report in very short time. Many clinical study was done to see the accuracy of the deep vessel FFR. You see the accuracy is really nice compared to invasive studies, which is 88.7%, and also sensitivity and specificity of deep vessel based coronary artery stenosis in predicting outcomes, very nice. You can see in 90s all the things. So for FDA, there was a trial, multinational trial was performed mostly in the USA and also in Europe and other countries, and that really surpassed what the target rate was, and really helped in showing that it is really valuable. And then on-site CTFFR performance was another thing, which is really good, where you can do right there, and it takes just a few couple of minutes or even less than that actually. And this randomized trial actually proved that the CTFFR on-site using machine learning is feasible, safe, and effective, and also it identifies the patient which really needs to go further for invasive procedures in these cases. And the advantages really are uses less computational power, performs analysis in minutes. That means very fast and on-site. You can do on-site also or other way too, and improves performance with more. So more data comes in, the more, you know, it improves the accuracy and the performance of the whole thing. And again, we also compared with the other with the functional dynamics also, and see the results. Just like HeartFlow has done quite tremendous work before also to validate this, and we compared with the FFR from flow dynamics also, and proven to be almost same or better in some cases. The results have been really tremendously comparable to this. So deep vessel FR, I'm just going to show you a couple of quick cases. This was a patient who came in, looks like a 70%, almost 70% narrowing there, went directly to an invasive study, which showed 0.88 FFR by ICA, but in this case, retrospectively, we did FFR by deep vessel analysis. That turned out to be almost same exactly, 0.088 and 0.087, so very comparable. So this could have been avoided if you had done the FFR CT right on the site actually with this. This is another patient who had chest pain, shortness of breath, and had wall motion abnormality, and you can see how critical lesions are there in circumflex and LAD, and how bad the FFR was there. So it's really fast acquisition, fast results on this, and this is another patient showing the same thing, and this actually had multi-vessel disease, and finally they decided to take him for bypass surgery. And it's another one also showing actually in OM, but it was very stenotic lesion in OM, and OM was big size vessel in this case, and he'd been complaining, and finally actually we see that CTFFR was really significantly abnormal in this case, and also went for further, and that's another case. So all these cases are really proving that how good this is and how fast we can get the results in these patients. And also machine learning model also showed that the kinetic changes in the plaque by doing serial CTA also helps in predicting the risk of acute coronary syndrome in these patients. And with the quantitative imaging techniques now, as we know, all we have been learning throughout the whole meeting, that powered by AI and machine learning, that we are shifting towards personalized data-driven treatment plan for coronary artery disease patients in this case. So the new product they have is Deep Vessel 2.0, which is basically a workflow platform. It's automatic segmentation. As you can see, it's called Cardiovascular. That's the platform gives you the stenosis roadmap, and also give you FFR and also plaque analysis. This is the product in tube which will be coming out soon once cleared by the regulatory. And as you can see, there's color-coded stenosis there in these patients. And you can see also plaque, calcified, non-calcified, and low-density plaque. It's really, as most industries going this way, but in the same direction, which is very interesting in this way. And we get, the more we do in these kind of things, the more better we get, and more faster results we can get. And decision making is fast rather than going to the usual path, which takes long and very expensive this way. And the other big marker actually is, I would say, the fat attenuation index, which is really tells you how perivascular tissue there's attenuation of fat, which is actually inflammatory marker, and tells you how bad the disease is, and how is also associated with high risk of cardiac deaths and poor clinical outcome in these patients. And that will be actually be coming out soon also in this coming quarter. And I think I would suggest very precise, very comprehensive, value-based, and streamlined, and also efficient. You can do very rapidly decision making in these patients, and also accessible as the results get right on your PC or your tablets or smartphones, whatever you want. Actually, it's very fast. So I think there's a lot more going on and a lot more coming out as we each time meet. And actually, in overall, it was very interesting. Everybody comes and presents this as that there's significant saving in cost and everything, and with the industry also showing everything that is saving. I think the SCCT should get something out of that too. Thank you so much for lending me your ears and also providing me. If anybody wants to get in touch with Keya, they're welcome to do that. And thank you, Keya, for letting me present here.
Thanks,
Appreciate
Irfan.
it. Thank you.
Thanks very much. Really appreciate it.
Thank
In the interest of time, obviously, we'll make room for the next session. We'll ask that the speakers make themselves available for questions outside. Thank you. Announcement, Koen?
Yeah, so the next session is going to start immediately following this, so I recommend, as most of you are doing, to grab a seat. There's lots of seats here in front. And I think we have one slide. Can we put the slide about the virtual reality up? Yeah, so for those who haven't tried this yet, please check out the CTCA Virtual Reality Technologies Training Prototype. So this will allow you to put on the goggles and see what it's like. We can really use your feedback on this, so if you have a moment, then try it out.
How you doing?
All right. Hey.
This is not mine. I don't know whose this is. We'll find it around here somewhere. Yeah.
Okay. Hello, everyone. Come on in and have a